welcome back to our CME series after a good break in December. I would like to introduce to you Home Nursing Foundation as the largest home healthcare charity in Singapore, and we've been providing home medical, nursing, therapy, as well as home personal care to more than 5,000 frail and vulnerable patients each year. We also run 2 senior care and community rehab centers and active aging centers in Hougang and Buangkok. And this year, we are excited to be able to provide advanced care planning as well as integrated community care as a case management service with the aim to improve the well-being, health, and function of the seniors in the community. Under the prolific clinical leadership of Dr. Ng, this series of CPE or CME was started to raise our understanding and the practice of holistic, person-centered care in the community for frail patients, and also benefiting their caregivers and empowering them to live well and joyfully in the community. Since 2022, we have started this series of CME. Some of the topics include end-of-life care, functional rehab, dementia, falls, osteoporosis, mental health, Parkinson's, wound management, caregiver support, social prescribing, asthma, and many, many interesting topics that are available for your viewing and reference on the YouTube using the QR code. And this afternoon, we are all very excited for Dr. Lim Kok Bin, who has very kindly agreed to spend his Saturday afternoon to share with us on this very interesting topic on urine leakage in men. So welcome, and I'll hand over the time to Dr. Ng Wai Chong to introduce our speaker.
Okay, thank you, Christina. So for those who are new to this webinar, Dr. Christina Cheong is our always energetic and always cheerful cheerleader of a CEO, our HNF. And today it's my pleasure to introduce my old friend and classmate, Dr. Lim Kok Bin. Dr. Lim Kok Bin has a very illustrious career as a urologist. Currently, he's a senior partner at Raffles Urology Center, Raffles Hospital, and the Vice Dean of the Academy of Men's Health, Singapore. He graduated from NUS and obtained his fellowship diploma from the Royal College of Surgeons in Edinburgh. He's a fellow of the Academy of Medicine in Singapore and has held multiple leadership roles, one of which was that he was the past president of the Singapore Urological Association. He has received many awards for his research on urinary stone diseases, Peyronie's disease, and he's completed a clinical fellowship in andrology and sexual medicine. So for today, as everybody know that our target clients, patients, and the recipient of our services are seniors and their caregivers. So many of the seniors, especially suffer from incontinence. So today we are focusing on the men related to urine incontinence, but also perhaps we will, if we have some time, we will also discuss about the management of chronic incontinence and urinary catheter. So the format today is like usual. Dr. Lim will give a talk about 45 minutes, and sometimes it's overrun, it's fine. And after that, we'll have a Q&A. Those of you who have questions, you can type onto the Q&A facility on Zoom. So let us welcome Dr. Lim Kok Bin to share his lecture.
Thank you, Wai Chong, for the kind introduction. As you have said just now, actually the focus today is all on the urine leakage in men, because if I were to include female, which actually quite similar, but there's always some differences, we will need more than an hour for that lecture. So today I'm going to concentrate on the men itself. Okay. Maybe
it's showing up very well. It's just that the animation is a bit slow.
yeah, because I think I got a hard time trying to
It's fine. Yeah.
or maybe okay, next slide. Or can Terence just go to the next slide for me? Okay, so before the the problem of actual urinary incontinence, usually they have some symptoms that already indicate something is not correct. So these are all the questions they always ask them, like whether they wake up a couple of times at night to pee, whether it's easier for them to initiate the flow, whether the flow is normal or slow. Important thing will be some of them will have this urgency. Sometimes it can be as bad as like half an hour after taking some fluid, they need to go. And all this culminate in urinary incontinence. Next slide. So there's three main separate group of incontinence. Although there's always a possibility of where there's a mixture of either one of them. So the three distinctive incontinence would be overflow, stress, and urge incontinence. Overflow incontinence basically means that the bladder is just not able to discharge all the urine, and it slowly accumulates to the extent that it overflows, just like you pour water into a cup of a cup, and then it just keeps on flowing out after it's full. Stress, on the other hand, is because of the defect in the continence mechanism. That means your sphincters are not working well, or due to very high intra-abdominal pressure pushing the bladder, and so that's why the urine leak out. Urge is usually some form of myogenic or neurogenic causes, where the bladder goes into overactive mode, and so despite it might not be fully full, somehow the bladder will just get triggered and discharge the urine. Next slide. So as I said, we're focused mainly in the men itself. And for men, the unique features is that we have this prostate gland. Next slide. So the prostate gland is actually a sexual organ. Unfortunately, it's located just beneath the bladder. And until now, for reason unknown, except we know that it's because of the hormonal imbalances as a result of aging that resulted in the prostate tissue getting more and larger. With that happening, the prostate grew and sort of constrict the urine passage as well as the bladder neck opening, causing problem with urination. Next. We have to mention prostate cancer, which is now the #1 killer, cancer killer in Singapore for men. They are not the same. Unfortunately, they can coexist. That means you can have a large prostate gland with a focus of prostate cancer within the enlargement. And they present the same way in the same group of men at the same age. So usually when anyone comes to us, one of the things we need to rule out is make sure that they don't have a prostate cancer. Next. So during individual specific incontinence, let's look at overflow. So before you have overflow incontinence, one of the things which is commonly seen is distended bladder. So if let's say the continence mechanism is very good, the sphincter is still very intact. So the bladder is just too full to the extent that the person will be really, really in distress. And the only way to relieve him is to insert a urinary catheter. Next. Sometimes you have this very unique presentation like nocturnal enuresis, as if the man has gone back to being a baby, so he leaks urine. There's two possibilities behind this. One, of course, something similar like overflow incontinence. Usually in this case, they don't really have a very full bladder, but they definitely have some urine remaining in the bladder, despite their best effort to pee. So maybe about 100, 200, or even 300 cc of urine. So usually, normally in the daytime, not a problem, but when you sleep, you're totally relaxed. And if you're really good in a deep sleep, then the muscle relaxation comes in and the urine will leak out, causing, back wetting. On the other hand, urge incontinence, very severe urge incontinence could also result in nocturnal enuresis, where, a bit of urine inside, most of us will be able to just hold on to it until we decide to wake up in the morning. But in this case, even let's say it's just 100 cc of urine, the sort of autonomic mechanism of the bladder function just push the urine out. So they leak up a couple of droplets into their bed sheets. Next. So yes, urge incontinence in the presence of enlargement of a prostate gland. What happens is that as the prostate gland enlarges, the bladder will try to compensate. Next. So as the bladder tries to compensate the hypertrophy, go to previous slide. Previous slide, please. So the bladder tries to hypertrophy because the bladder trying to push out the urine. It's just like you going to the gym, working out. So you pump more and more weights, trying to build up the muscle. So the same context, the bladder wall gets thickened, hypertrophy. The problem with that is that the bladder is a storage organ. So what it means, as you can see in the diagram, that the intradigital space, the space inside, becomes smaller. So what happens is that the person will have less capacity to hold the urine. And so if let's say he's still able to pee out without any obstruction, then you will have this frequent urination both daytime and nighttime because of the smaller capacity. Next. Now, what are the reasons, specifically that we are trying to deal with enlarged prostate gland? What are the complications that can arise if let's say we don't take care of it? I think the most frequent problem is frequent UTI. And that's the reason why any man with UTI or urinary tract infection, we have to evaluate to find out whether any underlying causes, and older men, BPH being one of the most likely candidate. Sometimes because the result of not able to discharge the bladder completely, you always have some leftover urine. Any of those minerals that's inside the urine accumulates, and you run the risk of forming stones. But the most important consideration is if you have a full bladder that doesn't empty, or you have a very thickened bladder, so thickened until it constricts your both urethral orifice, and that will result in what you call hydronephrosis of the kidneys, right? So the kidney gets swollen, and over time, if that doesn't get relief, then you might get kidney failure. So luckily, in the last 20 years, more men are more aware of their problem and seek help. So renal failure as a result of prostate enlargement, you don't see them commonly nowadays. But let's say 20, 25 years ago, you still see some men coming late where both kidneys are hydronephrotic with a large distended bladder. Next. So basically, any patients who come to see us for urinary tract problem, always a careful history and physical examination. Very important is a digital rectal examination because that will give us an idea about roughly the size and the consistency of the prostate gland. Simple thing that can be done in the clinic will be a urine analysis. Not uncommon that the symptoms of frequent urination when the person comes to you could be the starting point of having a diabetes. So sometimes we're surprised that just a simple urine analysis will give you an idea that maybe this guy is not having a prostate enlargement, but he's actually experiencing glycosuria. Body chart is important when evaluating a person specifically for frequent urination, especially nocturnal. Next. So it's important to look in certain aspects when it comes to deal with older folks with urination problem. Bowel habits is very important. Constipation actually can sometimes worsen the urination. So in order to maintain a good urinary habit, you have to address the problem of constipation. The pattern of urination and leakage is important to try to find out what is the possible type of incontinence, and then have a rough idea what we're looking at. Especially in urge incontinence, because one of the of all the incontinence looking at, again, those incontinence, the most dangerous one will be urge incontinence because it could be secondary to more so-called serious condition. So look for pain, look for discomfort, look for hematuria, because it could be due to a bladder stone or even bladder tumor. And then, of course, previous medical and surgical history and medication. When it comes to frequent urination and especially nocturia, to try to find out more about the medication is very, very important. Sometimes the diagnosis is made. For example, someone might have started the patient on some diuretic because he was on some blood pressure medicine and some of the blood pressure wasn't controlled well, and could have started on a diuretic just to help with the control of blood pressure without telling the person that it's a diuretic. And so it doesn't know that the frequent urination is because of the medicine. Alternatively, there's also nowadays the new SGLT2 medicine for diabetes, which basically causes glycosuria. So same thing, in order to try to treat them to control their sugar, or I think nowadays some of them also started on this because of the proteinuria, without telling them that it actually causes glycosuria, which means also frequent urination. Next. Yes, IPSS score, you can use that as to quantify the symptom severity. Although maybe in the clinic it's a bit too troublesome to go through all them one by one. Next. Next, yeah. So this is a example of the bladder chart. Usually, you probably have to do it like over 3 days. You ask the guy to sort of identify a particular cup or glass that he or she uses for drinking, and roughly know what's the volume of that cup. Could be 200 cc or 150 or 300, whatever. And then you roughly have estimate that if you drank half a glass is how much, or 1/4 or 1/3, and use that for all your fluid intake. Then if you can find a disposable container to measure the urine. So in the bladder chart, you're supposed to chart down what you drank, how much you drank at what time, when you pee, how much you pee out at what time. And then to take note of certain situations where you have, let's say, incontinence, you leak out urine. So you can see like there's some asterisks here and there. Those are the situations when the person may have leakage of urine. Next. Of course, for the specialists, then we will go one level up. To us, the most important is ultrasound scan, because it gives us an idea what's the exact size of the prostate, how it looks like, what's the shape, how much urine is left behind, so that in terms of, let's say, a urine leakage, because sometimes you may not be able to feel a full bladder. So the ultrasound scan will tell us that, is this an overflow incontinence, that's why it leak out, or a severe urge incontinence, that's why it leak out also. Next. This is a uroflow. The top graph is a normal flow. The bottom one is a slow flow. This is for further evaluation when, especially when the prostate is not especially large, you're not sure whether that's the cause of it. The next thing you can do a urine flow. So urine flow is good, then it's less likely a prostate enlargement problem due to other reasons. But it's slow, then yes, maybe it's still a prostate enlargement. Next. So all the other tests later on, I mean, I'm going to mention now is subsidiary to mostly urge incontinence or overflow incontinence that you cannot explain. This is just an example with a bladder stone on the top picture, enlarged prostate in the bottom picture, and the right-hand corner bottom would be a bladder cancer, which sometimes can present as very severe urge incontinence. Next. Yeah, PSA is important. As I said, prostate cancer is #1 cancer for men in Singapore. But I won't going to deal too much about PSA because that could be a separate lecture inside. But it's just one of those things that we will evaluate for any men above the age of 50 coming to see us for urinary tract problem. Next. Yeah, so if let's say there is a cause for concern of the PSA, then of course further investigation of transrectal ultrasound is important. Next. So it comes to management, unless it's an emergency, like you're really leaking out urine, overflow, whatever. If it's still doable, kidney is fine, occasional leakage, but not severe retained urine, again, we talk about bladder training, lifestyle, behavior changes, and plus or minus medication. Next. So depending on what's the problem, let's say, for example, urge incontinence or urgency, without evidence of bladder outlet obstruction, we actually advise them time voiding. Time voiding means that they will try to hold their bladder longer. So let's say they are peeing every 45 minutes. We tell them to aim at 1 hour. So just try the best effort, even though it's very urgent for them to just keep the urine for an hour. Once they can do that comfortably for an hour, then increase to an hour and 15 minutes. And then from there, 1.5 hours, and so on and so forth. So once they can do something like, every 2 hours, it's considered quite normal. Kegel exercise mainly for this stress incontinence to try to build up the continence mechanism. Biofeedback itself is not enough. Biofeedback usually is meant for people who cannot relax. So what happens is that the two things can happen when it comes to urination. One is too lax, so urine leak out. The other is too tense or too tight, that urine difficulty, but not because there's some obstruction like a prostate enlargement, but just the muscle is not able to relax, which can also happen. So in this case, there are specific physiotherapists, especially in this area, where they can do even ultrasound scan to see whether the person is deactivating the right muscle to relax to try to pee out properly. Next. Yeah, so we can do away things that might trigger off frequent urination like caffeine, alcohol, artificial sweeteners, spicy food, and ensure adequate fiber in your diet, more to make sure you don't get constipated. If you're overweight, there's a higher chance of getting this urge incontinence and stress incontinence. Remember, I mentioned to you that increased intra-abdominal pressure can affect your stress incontinence. Smoking tend to result in urge incontinence. Of course, one possibility is that smoking has a high risk of bladder cancer, but a lot of time when you check on these people, they don't really have bladder cancer. So I think what happens is that the byproduct metabolite of smoking probably causes irritation of bladder, causing the person to pee more frequently. And of course, in all circumstances, you can improve access. I mean, that one may not be easy to have maybe an ensuite toilet for every patient, but it is one way to try to eliminate the impact of, let's say, frequent urination, especially bacterial. Next. Yeah, so specifically for prostate enlargement, when it comes to medication, there's two main groups, the alpha blocker and the 5-alpha reductase inhibitors. One is to shrink the prostate gland, the other one helps to relax the bladder outlet, bladder neck. The alpha blocker works faster. It can kick in, the effect can kick in about 2 days, typically 5 to 6 days, and the effect continues to build up to even a month. While 5-alpha reductase inhibitors, it will take some time to shrink the prostate, usually more than 2 months, sometimes even up to 6 months. So for immediate relief, we always start with alpha blocker. If the prostate is really large, like 70, 80 cc, we may start combination treatment together with a 5-alpha reductase inhibitor, because eventually you still want to shrink down the prostate gland. So better to start early than start late, because as I said just now, it can take up to 6 months to shrink down the prostate gland. I do believe in herbal preparation, like saw palmetto. Especially nowadays, a couple of men usually go for their health screening. So they may not have much bothersome urinary symptom, but they could be detected a large prostate gland based on ultrasound scan. But otherwise, the rest is okay. So if they keen to try to sort of keep their prostate in a healthy situation, that means, yeah, prostate can be enlarged, but my pee is still okay. Yeah, saw palmetto preparation, like saw palmetto, may help to delay the onset of urinary symptom. Next. And then don't forget, as I said, we are concentrating more on the prostate enlargement, but part of the effect of prostate enlargement causes the hypertrophy of the bladder, resulting in overactive bladder. So overactive bladder itself can be primary due to age, or secondary, and one of these secondary cause will be a large prostate gland. So in this group of anti-masculinity, the non-specific type, which is elaborated here, buscopan, propantheline, imipramine. Some of the medicine probably not available now. And then the more specific one, like the oxybutylene, the taurodine, trospium, sulfenacin, popivarin, right? They all have common side effects like dry eyes, dry mouth, constipation, blood vision, and hypertension. And you have to be very careful when starting this medicine on men, especially men with large prostate, because it causes urinary retention. So one of the improvement last couple of years that they have this new beta agonist, mirabegron or Bemiga, which works a different way through the beta agonist pathway. Less side effect like dry eyes, dry mouth, constipation. So sometimes I use this just to make sure that the person don't get into urinary retention, especially I deal mainly with older men. In very severe, what I call neurogenic bladder with overactivity, sometimes may require a Botox injection to try to relieve the tension in the bladder. Next. And we also can do combination treatment for this group of people. Let's say, for example, I just now mentioned that you do a combination of a 505 reductase to shrink down the prostate gland as well as an alpha blocker. But what if the person has both a bladder outlet obstruction but also a problem with overactive bladder? So we can do a combination of an alpha blocker and an anti-muscarinic. Next. Of course, in very severe cases or cases where the medical treatment didn't work, then you can do a TURP. Next. Next. So in men, we shouldn't have stress incontinence as much as female, but with the increase in incidence of prostate cancer, next. One of the treatment options and the most popular treatment options is a radical prostatectomy. Next. Next. So whether it's open surgery or keyhole operation, next. Next one. So you can see in this diagram, okay, so essentially in radical prostatectomy, we take out the entire prostate gland and then we just sew the urethra to the bladder. So there's always a risk of damaging the sphincter. So nowadays we do see some urinary incontinence because of the radical prostatectomy. I mean stress incontinence because of radical prostatectomy. The other surgery maybe that also causes urinary stress incontinence would be abdominal perineal resection of the lower rectal cancer. But the abdominal perineal resection of lower rectal cancer usually can go either way. They either have stress incontinence or the other outcome is overflow incontinence, because somehow in some of the surgeons we're trying to do a wide resection to make sure the cancer control is adequate. It might damage the nerve to the bladder, so the bladder end up a bit atonic, don't have much contraction. Yeah, so also quite difficult to treat. A lot of times needing an indwelling catheter. Next. So for very bad stress incontinence, there are a couple of things you can do. The mild ones, we can put a tape, just like the same tape is being used in female stress incontinence. We have one for the men. Next. But in very severe cases, we will insert an artificial sphincter. So in this case, what happens is a three component of this artificial sphincter. You have a sort of a pump that you can pump to activate to deactivate the we call the sphincter. All right, this pump is hidden or buried in the scrotum, and then you have a saline balloon that is embedded inside in a groin area. And then, of course, the sphincter itself that surrounds the urethra. So usually the saline is in the this artificial sphincter that surround the urethra. That means the urethra is collapsed. Is sort of collapsed by the sphincter. And then when you want to go to the toilet, you press the pump. Then the fluid or the saline from the artificial sphincter will flow into the balloon and inflate that. And it will take maybe about something like 9 seconds or 11 seconds for the saline to flow back from the balloon into the sphincter. So during that 8 or 11 seconds, you're supposed to pee out your urine. And so let's say you cannot empty all in one go during that period, then you just press again. The sphincter will slowly relax, and then you let the urine come out. So that's how the sphincter works. Next. But if all else fail, then you resort to pads. adult diaper and indwelling catheter. So indwelling catheter, the main problem is always about hygiene and taking care of the catheter. Problem is that there's no good solution to ensure that you have no problem. All urine catheter eventually will have some fault problem. Either you get hematuria as a result of some inflammation or infection, or blockage because of debris accumulating. I mean, it's not a natural kind of thing to have an indwelling catheter. So you start having issues like biofilm that results in high risk of infection. The foreign material is irritative to the bladder. So the bladder will tend to shrink its mucosa. So that's why you got a lot of this debris, a lot of debris. And this debris can easily block the eye of the opening. And so you get blockage of the catheter. That's the reason why when you're using catheter, we always encourage more water intake. That's why it's a double whammy if the person cannot pee and at the same time has fluid restriction. And then it will be tough because probably will easily get blocked. In this case, then one of the better solution is to put a suprapubic catheter. Nothing fanciful. It's just that in the suprapubic catheter, your catheter is in the anterior surface. So whether you're sitting down, standing up, lying down, the debris will be on the dependent part of the bladder. Never get a chance to block the, honestly, never get a chance, but less chance of blocking your urinary catheter. So sometimes that's a solution. For if the person cannot be bringing off a catheter, just change it into a suprapubic catheter. Next. I think that's the end of my talk. So if there's any question, I'm more than happy to answer that.
Thank you, Kok Bin. That was a very useful topic, very practical, starting from analysis of urine incontinence to focusing on prostate and management of BPH. And we do have a few questions, and one of the anonymous attendee was asking a question I think many doctors would like to ask. Maybe I'll start with the one at the bottom. When we clinically diagnose BPH from PR examination, and do we still need Uroflow study, or can we start alpha inhibitors or alpha blockers or the finasteride? I mean, the other question is related. Should we do a PSA test, screen for prostate cancer before we start finasteride? So these are related to common issues faced by family physicians or home care physicians, because referring the person to see a urologist is going to be quite difficult for families.
So practicing urology for the last 30 years, to be frank, I seldom do Uroflow nowadays because I need it only in a certain situation. So, okay, so for me, maybe a bit different. I got a bit skewed. I have an ultrasound machine. I know what's the size of prostate gland is huge, obviously huge. Let's say those borderline like 30 plus, 40 plus, of course, we may have to do further check just in case. But obviously, big prostate, 60 cc, 70 cc, 80 cc, and the symptoms are suggestive of bladder outlet obstruction. I may not need a Uroflow to because it's there. The person really have a problem with large prostate gland, we just treat accordingly. And of course, the bigger it is, the higher chance I will start some finasteride or dutasteride. It's a good practice to have a PSA before starting the finasteride, because sometimes I don't. Occasionally not because I don't, because patients don't want to get done. But bear in mind that if you don't have a baseline finasteride or dutasteride, okay, I mean, it's not a sin that you didn't do it, so don't worry about that. But if you ever had a chance to do a PSA when the person already on finasteride, dutasteride, especially taking it for about a month, just bear in mind that the PSA should ×2 to reflect the actual full value. That means if it's came back, wow, good day, the number is 4, but actually it's not. It's supposed to be 8 because it's half by the medication, which is no good. Means it's PSA is 8 to start with, means it's high. So check further to find out whether there's a risk that's a prostate cancer going on. Yeah, so your number that you want to see if the person on finasteride or dutasteride is less than 2, 2.5, 1 point something, because your times 2 is the actual PSA for that person. Okay, so
So you're saying if a person's if he's taking
finasteride or
right, their PSA level should be twice the baseline, right?
right. I mean the PSA will be half because of the medicine. So whatever test result you have should be times 2 to show the actual PSA.
Oh, okay, I see. Because okay, you'll be half, but you just have to times 2 artificially, manually, just to reflect on the true PSA.
Yes,
okay,
correct.
I see.
So that's it. So I don't want to say that you must do a PSA before. So sometimes it's not possible. For example, I do sometimes start the person without a PSA because he's going to schedule for health screening 1 month later. So I know doesn't make sense for me to do a PSA now just to see what's the level. But it's really symptomatic. So it's okay. I just know that he's been taking the medicine for a month. When he come back with the health screening, I'll say, okay, I just times 2. Okay, as long as within the normal range, just take it. And test result is not just a one-off thing. You'll be monitoring it at least yearly. So the trend is important, right? Sometimes PSA can be high. Let's say some guys PSA is like 4 point something, but over the years always 4 point something. It's better than someone who's from 1 point something, become 2 point something, become 3 point something, become 4 point something.
The trend that's more important.
The trend is more important, right? You don't just look at one snapshot. So we don't get too hard up about the PSA. I mean, if you have it, good. It doesn't have it, doesn't mean you cannot start taking the medicine, especially if the person is very symptomatic. And then PSA, then the other one is so I don't really start on urine flow because you can actually. So when do I use the urine flow? When somehow the patient said, it doesn't work. Wow, then I got a headache. Although yes, indeed, sometimes the medicine doesn't work. But then I have to look into other things. So I'll say, okay, let's do a urine flow and see what's the pattern like. So just a quick way, of course, is do a cystoscopy. You know what's happening, but I think it's an invasive kind of procedure. So you do a urine flow. If the urine flow is really flat, despite taking the alpha blocker is really flat, then this guy may have a stricture somewhere. Sometimes it can happen. You may have a previous traumatic catheterisation by somebody and then created a stricture without knowing. So the treatment is to find out whether it's a stricture and then you dilate the stricture, then solve the problem and not the prostate issue. So I do urine flow sometimes, not because I need it to start the medicine, but more because the medicine didn't work. Then I find out why is it not working. Although bear in mind, yes, there's some medicine that doesn't work. But instead of just, okay, this medicine doesn't work, switch to another one. I mean, one alpha blocker and the other alpha blocker, not much difference. The main difference is the side effect. Right? The effectiveness is probably about the same.
So that means we can start alpha blockers as even like a diagnostic trial, right? If it doesn't work, then we do uroflow. And you mentioned about the volume of the prostate. We don't really get transrectal ultrasound easily accessible. So we can go by the IPSS symptoms, right? And then PR feels like the prostate is a bit big, then we can start alpha blockers.
Yes, so there's a few things as a surrogate. The symptoms have been shown to the more severe is more likelihood enlarge. The flow pattern, if you have, also tell us the enlargement. The rectal examination is not sensitive enough, but if it's obviously enlarged, you will know. And then a good, so-called more, I would say, objective assessment is the PSA. So PSA is also a reflection of the size. So sometimes the PSA maybe like borderline high 4 point something. It may mean that it's a large prostate gland to start with. So let's say a PSA coming 1, usually the cutoff is 1.5. So anything 1.5 and below, chances are prostate can't be too big. Especially if PSA is less than 1. It's not that it's not 100%, but it's just that the chances are not so high. But once it's something like 2.5, 3, what it means is that they don't have prostate cancer, but there's a chance he has a large prostate gland.
So what you're saying is that even lab tests can also be diagnostic tests for prostate enlargement, BPH. That's very interesting. Very good. Thanks. Okay, there are a few questions related to nursing care. There's one on bladder scan. There are a lot of nursing homes, even home care. We actually use bladder scan. The question is it accurate?
Yes, it's actually accurate. It's accurate, but there's some fallacy which even for a non-experienced urology might even not able to detect. So so basically what what the bladder scan does is just to measure a space, I guess. They can measure
Yeah.
this space, which I assume is the bladder because you're just pointing down the suprapubic area.
Yeah.
So there's one time, and it's quite accurate. So, okay, we don't argue about the minor difference. Like let's say,
Yeah.
oh, I measure usually my fantastic ultrasound scan 100 cc.
Yeah.
And then the nurse bladder scan is 90 cc.
Yeah.
I mean, the kind of 10 cc difference, come on. I don't get
Yeah,
too head up about that.
not
Okay.
significant. Yeah, big
But that was
coincidence.
a situation where high residual urine, but urine catheter was not much.
Mm.
That was bladder scan. So I myself also do my big side ultrasound, look at it, how come don't have? Then I try to figure out, then I realized this guy had a big anthrocyst. That means
Oh.
the cyst of the, so what we are looking is a cyst of the intestine.
Okay.
Yeah.
I
But
see.
it's not a bladder. So I had to figure out, I myself have to figure out, how come there's a thing there and yet there's not much urine. Then of course the first thing you see, such a big thing without, just the catheter is already in place.
Yeah.
But I can't see the balloon of the catheter inside this empty space.
Yes.
So it makes me wonder, where did the balloon go to? So you
Yeah.
flip here, flip there, realize, oh, the bladder is below, it's empty, there's a balloon there. So that
Yeah.
part is something else. And then
Yeah.
turned out to be a anthrocyst. Anthrocyst means the cyst of the one that intestine.
But
Yeah.
that's not common. So generally, for intents and
That is
purposes,
actually quite
bladder
accurate.
scan
Yes.
is quite accurate. There's
Yes.
another question related to nursing care. Do we recommend double voiding? Because you mentioned, because in BPH, right, sometimes they got high residual urine. Can we recommend double
Yes.
double voiding?
Yes. So the only thing maybe sometimes I don't recommend for men with possible bladder outlet obstruction is pushing too hard.
Yeah.
But if let's say they are okay, not that bad, so you have to assess. Actually, I do tell them can do a double voiding, and some of them automatically do the double voiding. They'll come back and say, yeah, I need a second P. So they will know that. So one of the questions I always ask is that when you end, do you feel it's empty or there's something left behind?
Yeah.
So one of the questions one of the response will be that, yep, they felt there's something left behind. They wait for a few minutes and the second P come out and then they go out. And
Okay.
as long as they don't get bothered by that, I'm fine with that. So again, for me, in terms of symptom, more important is the bothersome. So you can have a patient who wakes up, let's say 4 or 5 times a night, but it doesn't bother him because he goes to sleep straight away and wake up fresh the next morning, versus someone wake up exactly at 4 a.m. in the morning. So that 4 a.m. wake up is irritation to him, and that bothers him. So even for that guy with one time wake up at night at 4 a.m. is a problem, which I need to try to solve for him. And the guy who has 4 or 5 times, because it doesn't bother him.
Maybe we need to manage the expectation.
Just if the person doesn't bother, why should I bother about it in the first place? As long as there's no implication in terms of kidney function, UTI, that kind of thing, why am I supposed to bother about it?
Yeah. Thanks for that. Actually, it's related to a point that was raised in the chat as well. What do you accept as a acceptable cutoff volume post-void?
Yes.
Post-void, you say sometimes we wean a person off catheter and then we do a bladder scan and it is immediately after P is 300. Is that acceptable?
So that's a bound for debate. And as I get older, I tend to be more lenient.
Okay.
Yeah, so usually that time the senior urologist say, oh, 100 is the cutoff, and you really stick to that number 100. Then as you realize that, oh, if everybody stick to 100, I gotta put catheter for almost everyone.
Yes.
So my number changes to 150. So I think you have to look at the context of the situation. If the person is okay, I'm happy, I don't think I have a major problem, but the residual urine is always 150 and more, then you tell the guy, warn the guy that, you know, he can easily tip himself towards acute retention one day. Let's say he took some cold medicine, you know, anticoagulating agents and stuff that. On the other hand, if the person was on a catheter and just begin to wean off, so I may accept 300 cc because you know that it takes some time for them to slowly recover. But of course, I have the luxury of seeing them early. So usually, let's say for example, first of all, they need to be able to pee. So we have a urine flow. So urine flow can be very bad. Sometimes, a lot of times it's bad. It's like literally flat line. but came out 150. Okay.
Mm.
Then he left over 250. Sometimes I accept that.
Yeah.
Then continue the alpha blocker, whatever, and then but TCU earlier, just to check. So because if not, the indirect catheter is not the solution of his problem.
It's very troublesome. A lot of problems.
It's not troublesome. You never had a chance to pee.
Yeah.
I mean, a better method would be a clean intermittent self-catheterization if you just drain the whatever leftover urine. Because if you put an indirect catheter, the guy will never had a chance to pee to prove himself whether he can pee or not able to pee.
Yeah.
So you have to a bit of compromise. So, but of course, it's 400, 500 is a different story.
Yeah. Okay.
But 300, I sometimes still say, okay, why don't you continue medicine? At least it came pee out 100 plus 200. Say at 300, it's okay. Continue medicine. I will see him earlier, maybe 5 days later, just check again.
Yeah.
So what I've seen is that they actually every week coming, the residual urine drops.
Oh, okay.
300, then next one come 250, next time come 250, improves that.
Okay.
Because I remember I said one thing just now, that the alpha blocker effect is it continues to accumulate over about a month. That means the effect can kick in as early as 2 days to about a week. But after 1 week, doesn't mean it's stagnant. The effect stagnant. It's continue to improve up to about a month to 6 weeks.
Yes.
So don't just
That means, can I say it like this? That the problem with residual urine is that there is an increased risk of infection. I mean, obstructive uropathy is not a big deal these days, right? So, but it is actually the increased risk of UTI. But IDC itself also increases UTI risk.
Yes.
So if I were to wean a person off the catheter and they can manage PVRU or 300 and the person doesn't feel uncomfortable and using, say, a diaper or diaper as accident, can still use a toilet.
Yes.
We can accept that, right?
Yes.
Yeah, okay.
You're right.
Okay.
Correct.
That'll be very good for quality of
even
life.
the best nursing care, you can never avoid a UTI in a long-term IDC.
Yes. Okay, that's really helpful. Okay, another question from the audience is related to what is acceptable urine frequency in an 80-year-old man having BPH, taking Zatral. What would be acceptable?
Okay, let me put it this way. Typically, let's say for a 80-year-old man will be a bit challenging. We can calculate a different way.
Yeah.
Let's say a normal 40, 50-year-old man, maybe you sleep about 8 hours. Okay, just put 8 hours easy. So you have about 16 hours a week time. So a good frequency will be peeing every 2 hours. So you're peeing about 8 times, right? 16 divided to 8. So that's probably the number looking at average. So for older men, 80 years old, what happens that they probably don't sleep so much. So maybe a bit more. And most of them may be so as you get older, there's this more likely to get a bit of nocturia. That means you probably pee a bit more of your urine in the nighttime than daytime, which we accept it maybe up to 30% of the urine coming out at night, or rather the sleeping time and the waking up time. But of course, it's more than that, then it's a bit tough because then it's frequent urination at night, then we have to deal with it. So roughly that's what we're looking at. Every 2 hours, if you have adequate water intake.
Okay, there's a question about PSA, the cost benefit of it. The question is about weighing it against the natural lifespan of a person who is at risk of I think the question is phrased like this, but I think the point is really that what is the rough expected lifespan of a person that makes a PSA irrelevant? Too old to look for prostate cancer, or better not to operate because operation risk is too high? Is there such a thing as a age that we shouldn't do PSA anymore?
Yes, I think there is. The only thing is that sometimes we have to realize that our so-called expectancy is getting older and older. So my cutoff getting higher and higher because man is getting older and older. Okay, there's a couple of things you can see. Like for example, a good example I like to give is TURP.
Yeah.
TURP for prostate enlargement is not a cure.
Yeah.
You still can have recurrence. It's just I can tell you next 20 years you're fine.
Yeah.
And because last time our life expectancy is about 80, so I always offer this TURP on 60-year-old and above. Seldom more than less than 60, I'll offer them.
Yeah.
A couple of months ago, I see a guy, he's already 80 years old, and his surgeon probably did the operation when he's 60.
Yeah.
And now he's a bit of a problem with urination. But it's going strong. He's very fit 80-year-old. So,
Yeah.
so what I'm trying to say is that our goalposts have to change. It has been studied very, very extensively that it takes about average of 13 years for prostate cancer to develop from a localized cancer to metastatic to death.
13 years.
So
okay.
13 years. So you work backwards. Okay. So if the person is 80 years, obviously forget it. All right.
Yeah.
Even 70 years old, you have to argue because our life expectancy for men is about 83, is it? Or 84.
Something like that. But it's starting from the point of birth. If you hit 60 without any problem, you can expect to live to even later.
But I use the death as a cutoff. So anyone at 70, I give them a choice. Above 70, I hard time trying to want to do PSA. So sometimes if the person come, let's say first time seeing a urologist, already 75. I actually very frank with the family and say, all the things can be checked is PSA, but I won't offer because I don't find any risk of cancer. And even if there is found out, he's going to die with the cancer inside rather than, from there. And if they understand that, fine. If they want to insist, then of course, I'll do for them. Because it doesn't make sense. Because early cancer at the moment, for any men, we are supposed to offer them active surveillance as one of the choice. That means you don't do anything. You don't do anything, but doesn't mean you give up on them. You don't do anything, but you monitor them closely. Yeah.
Okay, there's one more question from the audience. I like to ask this, but I like to reserve the last question for myself. Okay, the last question here is, you mentioned about taking alpha blocker and also muscarinic agent. Okay, so this question is about, say, an 80-year-old man taking Zatral, still having frequency, maybe it's 1 hour or every half an hour to 1 hour. What would you do to treat the frequent urination?
So it depends on what's the frequent urination. Is it more nighttime, daytime, or is it throughout the entire day? Look into their water intake. That's why the bladder check sometimes comes in very useful.
Oh yeah, correct.
I have one where I decided to, because no matter what I do, it doesn't make a difference. So I got fed up, I asked him to do a bladder chart and realized that he drinks 5 liters a day. So it was surprising because that's the first time I ever see 5 liters a day. And then someone can tell me, sometimes I drink more than that. Okay. But luckily, no water intoxication. But what I'm trying to say is that there are people who drink that amount of water. If you're telling me you drink 5 liters a day, and to be frank, I mean, our bladder capacity, probably 500, you're really urgent to go to the toilet, half a liter. So even you divide by 500, you're going to still pee 10 times a day, 10 times a day, minus away the sleeping time, you literally every less than 2 hours you go to the toilet already.
Yes.
So it's a simple math here. So I think if really sometimes you cannot figure out why, just ask them to record down. In fact, you don't have to tell them to record down how much you pee out. Just record down how much you drink one day also can.
Yeah.
Then realize, wow, so much.
I see. So actually, the thing is, we should investigate with bladder charting. If it's really confirmed, then we just have to exclude, are you taking coffee, tea, and so on. Then
so
if you're not,
those,
then you take oxybutynin, propentylene, you can do that, right? Your alpha block already.
Right. It's just that they tend to have more side effect compared to the muscular one. But still, all of them have side effect. Usually, the problem with anti-muscarinic agent, the side effect is worse for older people. I've come across one lady came in when I was a surgical resident for severe abdominal pain, 80-year-old lady. Lucky we didn't do anything because realized the pain is due to the digital he was taking.
Sorry again.
The digital. Because of the
okay.
constipation, call it so bad until it was severe abdominal pain.
Okay, I see. Yeah. Actually, for people with dementia, it will cause confusion also.
Yes.
Yeah.
Right. Yeah. So I'm very reluctant to give. When
Yeah.
I mention about anti-musculation, tend to be the healthy older men.
Yes, yes, indeed.
Yeah.
Okay, the last question, we have 5 minutes. Okay, this is a question that, in HNF, we do multidisciplinary discussion. Frequently, almost every time, there's this issue of a person who need the indwelling catheter change once a week or once every few weeks because it's always blocked. There are a lot of sediments. And we try to alkalinize the urine with cranberry juice. Sometimes we give pot seed, all those things that didn't quite work lah. And you can't quite take the person off the indwelling catheter, or maybe we could, but it's just that how do you manage such a troublesome indwelling catheter situation? A lot of them are bed bound, maybe limited prognosis, but yet we are still providing palliative care with that indwelling catheter. So how do you manage that?
I think I mentioned just now one of the solution I will offer is a suprapubic catheter.
Yeah.
It is because basically once you have sediments inside, it's always inside. Because the person with the indwelling, they cannot pee properly. So the sediment will never pee out.
Yeah.
So it's always a dependent part of the bladder. So if you, let's say you're standing up, it will be the inferior part. When you're lying down, it will be on the posterior wall.
Yes.
Or in the anterior wall, you will lie prone.
Yeah.
So by having a suprapubic catheter, you will sort of try to remove the opening away where the debris is.
Yes.
Because if you do the usual way, is where the debris is. That's why you can get blocked. So you try your best, ask guys to drink a lot of water, try to alkalinize the urine to reduce the debris, whatever. But despite your best effort, it still happens. Then the only way is to, of course, the best is to bring it off the catheter. If not, suprapubic.
So I suppose from what you said just now, one way is if we take off the catheter and the post-RU is 200 to 300, maybe we just leave it out, right?
Yes.
The person can, yes.
Yeah. I mean, you telling me sometimes this patient, they probably don't even realize they have a high RU.
Yeah.
So you basically just monitor them. I think like you said, the final outcome is whether they got UTI.
Yes, yes.
Yeah.
Okay. Then there are other things that sometimes we do like sterile intermittent flushing, right? With sterile saline or chlorhexidine solution. Some people do that. Or what else do people do? Use very large bore catheter, would that kind of thing work?
If it's catheter, it's going to get blocked. Whether it's large bore less likely to block, but still will get blocked eventually.
Okay.
So not that fantastic. I forgot one more thing you can do. You can still always do clean intermittent cell catheter. I mean, not cell, but clean intermittent
catheterization. Yes.
So for example, for ladies, right? I mean, if IU is not so high, if you want to, you can check maybe once a day or once every 2 days just to drain out the extra urine. There may not be a lot, but maybe there was some. Then you just do it once a day. That's enough.
Yes.
Without need to put on IDC long term. I mean, that's one way. Female usually is easier. The only challenge comes to men. That's why I said the men is a bit difficult because first of all, you need the expertise and the experience to put a catheter.
Yes.
I mean, doctors also had problem putting catheter for men before. So others. So that's the only challenging part. But let's say it comes to a female, I think one way is just change to a clean intermittent catheterization.
Yeah. Yes. Okay. I mean, the other thing that we usually use catheter for is a severe sacral ulcer that we need to keep the place hygienic. So we have to use a catheter, and then we have to manage all the complications of IDC. Okay. So I think I've covered all the questions from. Oh, there's one more question. Okay, there are two questions I see. I don't know whether copy want to answer together. If we don't offer TURP to a person less than 60 years old, then what is an acceptable solution to resolve ARU? The second question is, how urgent is a blocked IDC? How long can patient wait before we go to A&E? Pain or what? Usually a lot of time is actually overflowing around the catheter. Yeah.
The first question is TURP for younger men, is it?
Yes, younger men, less than 60 years old.
I mean, in my career, I've done only 2 person younger than 60.
Oh,
And one is because he's one of those unfortunate guys that have a enlarged prostate from very young age.
oh,
So nowadays we do see quite a number, like even the late 40s are very big, like 70, 80 cc prostate enlargement already. And so he's been taking medicine throughout his whole life, from alpha blocker to combination treatment.
yeah.
So I think he did his TURP when he's 58, because after about almost 10 years of taking medicine, he said, "Doctor, literally no sex life already, no semen. So you really tell me after TURP, no semen, maybe affect my sexual life. There's nothing different than what I am now."
Yeah.
But of course, the saving grace is that after TURP, he doesn't take any more medicine. So
Yeah.
that's one of the earliest guy I did. And recently I had one guy, which I did also, but he's very young, younger than you and me. He's only about 52.
Oh,
Because what happens is that sometimes in young men, they have this unique feature where their middle lobe is larger. So the overall prostate is not that big.
yeah.
If we call it median lobe enlargement, the median lobe is large. And median lobe enlarged is the more challenging to treat, because a lot of the alpha blocker or the alpha reductase inhibitor doesn't really deal with purely a median lobe enlargement.
Yeah.
So it didn't work for him, and he developed side effect for all the medicine. I remember he gave him tamsulosin, alpha-sozin, one of the other finasteride test, right? He all has side effect, including I even asked him to take Cialis, tadalafil also has side effect. So he just lived with it until that day he said, "Doc, I just want to get it with." So, but you don't do a TURP, just remove because the prostate actually is quite okay.
Yeah.
Usually the prostate is not enlarged. In fact, it's quite normal. It's just the median lobe is abnormally enlarged. So you get rid of that only, don't keep the rest. So by doing that, he got a nice pee now, and he's still able to ejaculate.
Okay.
Yeah, but they let them earn the surgery. I don't want to push for them, because I try to do surgery prostate for men younger than me. Yeah, because I can't guarantee the sexual function after that.
Yeah. Okay. So the last one is, can we
the
leave
last question?
Yeah. Yes.
The question is what?
QRP and a young person.
Young
The,
that's
the last one is about block IDC. Can we leave it? Don't change.
Okay, block IDC is like ARU. So
Yeah.
it's block, but the interesting thing is sometimes you change the position a bit, it will flow again.
Okay.
You get me? If you flush cannot make it, the guy just turn around, the flow will start coming out. You will notice in the walk, doctor, the thing block, ask the ulcer to come, ulcer never come, then long, but then I come, flowing again.
Okay.
So
we will try that
next
time.
It's not as urgent as retention, but it's a problem that has to be solved one day or the other. So it's not like urgent, like must do now, but eventually the next 24 hours, you probably want to solve the problem. Or keep on having this issue. And a blocked catheter probably higher risk of getting infection than a ARU.
Yeah, yes. Okay. I think with that, there are no more questions from the floor, and we have overrun by a few minutes. And I'm really grateful, Dr. Lim, Kok Bin, so kind of you to spend an hour, and like all our speakers, these are all voluntary work. We don't compensate in numerary in any way. So this is really out of kindness to the fellow colleagues in the community, doctors and nurses. So really thanks to you for your generosity in sharing your knowledge. So with that, I'd like to wish everybody a happy New Year and a happy Chinese New Year next week. Okay. So with that, next few months onward, we are going to have a series of psychogeriatric lectures by Dr. Sin Wen Lee. It will be very interesting. Okay. So I think that's all right. Okay. Okay, goodbye. Goodbye, everybody. Thanks for being.
Thanks.
Bye-bye.
Bye-bye.